This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. Today on the Neurology podcast, we're joined by Mary Schroth. Mary is a pediatric pulmonologist specializing in spinal muscular atrophy, and she is the Chief Medical Officer at Cure SMA. We're going to discuss the recent Neurology Clinical Practice article. It was e-published May 24th, and in the August 6th Neurology Clinical Practice issue titled Spinal Muscular Atrophy, Update and Best Practices, Recommendations for Diagnosis Considerations. Mary, I'm really looking forward to learning from you today. So much has changed in spinal muscular atrophy in the past several years, even since that last practice guideline in 2018. I'm hoping we can focus on a few things today, bring me up to speed. So a review of the current treatments, their uses, and the state of the testing, even how we approach patients when the disease manifests itself in later childhood. But first, before we get into the spinal muscular atrophy, SMA, I'll call it subtypes in a minute, what are the big changes in this new set of SMA recommendations?
So the publication adds to previous SMA care recommendations with information about SMA newborn screening, which has been implemented, and I'll talk more about that in a little bit, and also additional information about adult onset SMA, which is an entity that we don't know a lot about and is relatively rare compared to the SMA that presents in early childhood. Also essential to the care of patients with SMAs, including patients and caregivers as essential partners in decision-making and care delivery. That was emphasized in this publication as well.
So several changes. I know that there's different subtypes and phenotypes, and how are they defined genetically in childhood?
So SMA, we all know, is a neuromuscular disease. It occurs due to a deficiency of the survival motor neuron, or SMN protein. SMN1 and chromosome 5 codes for the full-length protein. But if both SMN1 genes have deletions resulting in no protein production, SMN2 serves as a backup gene and produces some SMN protein, but much less efficiency. What we know is that the higher the number of the SMN2 copies in general, the less severe disease, but the correlation is not precise. With the availability of truly disease-modifying treatments for SMA, the classification by type no longer applies to everyone with SMA. The historical type classification applies to older children and adults and is defined by age at which symptoms onset and the highest motor function achieved. The most common type at birth is SMA type 1, and these individuals present with symptoms prior to 6 months of age, and they never sit independently. SMA type 2 makes up the majority of the prevalent population, so those currently surviving with SMA are predominantly SMA type 2. And SMA type 2 is defined by symptom onset of weakness of the proximal muscles between 6 months and 18 months of age. These individuals achieve independent sitting and are not able to walk. People with SMA type 3, which is more rare than type 1 and type 2, develop symptoms typically between 18 months and 10 years of age and present with an abnormal gait, or they're slow to start walking. Adult onset SMA, or type 4, occurs in adulthood, most often after 30 years of age, but can present sooner and should be considered for any adult with a history of proximal weakness, proximal muscle weakness, frequent falling, not able to keep up with their peer group when they're running or playing sports, complaints of muscle pain or cramping. For infants identified by newborn screening and treated prior to symptom onset, they do not fit the type classification and are best described by SMN2 copy number, current motor function, age of symptom onset, and severity of symptoms if present. After treatment, these infants that are treated very early, also noting the age and level of function at the time of starting treatment, are important features.
Regarding the diagnosis of these severe early onset patients, including all the ones who are symptomatic before that cutoff of 18 months of age, what is the state of newborn screening in the year 2024 in the U.S.? Does every state have it yet? Are there gaps remaining? Where are we with that?
Nationwide SMA newborn screening was recommended after nusinersen was approved, the first treatment for SMA, and after the first successful SMA newborn screening pilot program. Shout out to New York State. As of January 2024, SMA newborn screening has been fully implemented across the United States and Washington, D.C. We did it in 5.5 years. Truly amazing, and due to the perseverance and advocacy of the SMA community, including healthcare providers. Newborn screening is variably available outside the U.S., but is making gains. Some countries have fully implemented SMA newborn screening. Some countries are conducting pilot studies, and some are still in the planning stages, so it is quite variable. The limitations of SMA newborn screening are that it detects 95% of all babies born with SMA. That means that 5% will be missed due to heterozygous SMN1 deletion and a single nucleotide variant on the other allele. These individuals will develop symptoms and require an astute clinician to recognize the signs of SMA and obtain further diagnostic testing with SMN1 gene sequencing. So if you see a baby, an older child, an adult with symptoms suspicious of SMA, and for the babies, young children who had positive newborn screens, they may be someone with this point mutation, we call it. So they need further testing. Trust your instincts as a clinician. It looks like SMA.
Got it. And we know no test is perfect, no exception here. It is all about clinical phenotype, right? And phoning a friend too, when in doubt, if it seems like it and everything's not quite lining up. And in this day and age, doing it promptly. But that's a fantastic achievement. So glad to now know that. I wasn't aware that every state and Washington, D.C. now has the testing available. So once the diagnosis of SMA is secured, can you review for me, because I think I'm behind here too, what are the available treatment options for SMA in the U.S. currently? I assume also variably available internationally.
After decades of unsuccessful research looking for a cure for SMA, a breakthrough occurred in the early 2000s that led to the first treatment for SMA. Currently, we have 3 treatments that are approved by the FDA and the EMA, and all 3 result in increasing the survival motor neuron or SMN protein. So these are treatments for the genetic disease. You have to have the mutations in order for these treatments to be effective. Keep in mind, though, that none of these treatments are cures. So everyone who receives these current treatments still has SMA. Nusinersen, known by the trade name of Spinraza, and risdiplam, known by the trade name of Evrysdi, act on the backup gene, SMN2, to alter messenger RNA splicing and results in increased full-length SMN protein production, but they don't replace what the SMN gene would have produced. These treatments are approved for everyone with 5q SMA. Nusinersen is given intrathecally in an outpatient setting with 4 loading doses over 2 months, then maintenance dosing is every 4 months. Risdiplam is given by mouth daily at home. The third treatment, onasemnogene abiparvovec, also known as Zolgensma, transfers the SMN1 gene via viral vector intravenously, given only once, and is available only to children less than 2 years of age with 5q SMA. Children treated with Zolgensma still have SMA and will pass on their genes for SMA to their children.
So 3 treatments, that's really helpful. And I know we do have a podcast back from March 31st, 2022 for anyone who wants more detail on that, where Gordon Smith was talking with Charlotte Sumner about these treatments early on. But now here we are in 2024. So I want to ask you, Mary, what do we know about treatment outcomes? Because the oldest children treated originally with the first medication might be elementary school age by now. Is that right? How are these children doing?
These kids that were in the first pivotal trial for nusinersen are now in school, and these were symptomatic kids with traditional classic SMA type 1. They continue to have symptoms, but they are doing so much better. They are surviving longer. These are truly disease-modifying treatments that are currently available. Again, not a cure. What we've learned through these clinical trials with these treatments, though, is that early treatment provides the best outcomes. As many of my neurology friends have told me, time is neurons in SMA. Children treated younger than 6 weeks of age in the clinical trials are currently in school, and they're doing great. Are they perfectly normal? No, they are not. But compared to natural history, their lives are dramatically better. Children who would have been predicted to have had SMA type 1 are walking. They're going to school. They are not needing respiratory support. They're not needing nutritional support, which is typical for babies who were diagnosed with SMA type 1 and developed symptoms. Children who were treated earlier and were part of the clinical trials, they are surviving longer with reduced, fewer comorbidities. Now with widespread availability of these treatments and use of these treatments in the larger population of individuals with SMA, we're learning more about emerging issues such as possible neurocognitive effects, and also trying to better understand the development of scoliosis in young children. There's also kidney involvement. There are emerging comorbidities that are coming out as a result of, I think, individuals with SMA living longer, fewer of the life-threatening comorbidities.
Work to be done to optimize function even more, but to your point, these were perhaps medical comorbidities that didn't even come to the surface before because it was fatal. Is that fair?
That's totally fair. Or in the case of individuals with SMA type 1, they did not have the communication skills for them to be adequately assessed regarding neurocognitive function. So there's just a number of issues that we are learning. So we're not done. We're not done developing new treatments. We're not done understanding this disease. As you said, there's lots more to do.
And let's talk a bit more about some of those other groups you alluded to. So if you have symptom onset, say after 2 or 3 years of age, maybe even into early adulthood, what do we know about this population? How do they even come to testing? And has anyone yet tested any of these treatments in these later onset, presumably more mild phenotypic groups?
Yes. All of the treatments have been tested in what's called later onset SMA, which SMA type 2 and SMA type 3 are grouped into. So these older individuals presented with symptoms, so typically weakness, or they miss developmental milestones, or for the adult population, which we're trying to understand more about, they are presenting with weakness that looks like a lot of neuromuscular disorders, and it's much more difficult to sort out. Do they have SMA or do they have an underlying myopathy? Later onset SMA has also been studied in clinical trials of the 3 approved treatments and have demonstrated improvement. The improvement is not as dramatic as seen in those who are treated pre-symptomatically, but they're still showing significant gains in motor function and quality of life and other measures. We also have observational studies of adults receiving treatment, and they are showing improved clinical course of SMA. So the expectation about what's considered improvement is a little different in children compared to adults. With children, we're looking at development, achieving developmental milestones. In adults, we're looking for stabilization of disease, slowing progression of SMA compared to natural history. All of those are wins. If we can improve an individual's quality of life with these treatments, it's a win.
Agreed. This has been a huge change, even for me to watch over the past 10 years, and really just so exciting. One doesn't often see change in that short time frame in medicine, though, but in such a severe disease. So what do the next 10 years ahead or beyond look like for SMA? What is next on the horizon? What are the most pressing issues you're working on?
So among the most pressing issues are really the changing needs of the SMA community. We know that today, more than 50% of the people living with SMA are adults. And that's a huge shift in how we all think about SMA. It's been thought of as a pediatric disease forever, but it's really becoming an adult disease as well. So there's a tremendous need to build capacity to provide care to individuals with SMA at the highest level possible. The other thing that we know is that 30% of the SMA community are not on treatment. One of our goals is to improve access so that everyone who wants a treatment has access to treatment for SMA. New combination treatments are coming forward, and they're focused on muscles, such as myostatin inhibitors, along with an SMN enhancing treatment. They're in phase 3 clinical trials, and we're optimistic that these are going to get to the finish line. And we're confident that these treatments are going to get to the finish line. The preliminary results are very promising. So there's more treatments in development. Cure SMA as an organization is funding research to look at additional targets to treat SMA and potentially develop treatments that will impact this disease. I really want to speak to adult onset SMA. This is I believe, an under-recognized form of SMA. And it may present with a history of difficulty keeping up with peers while playing sports, or frequent falling, or a mini myoclonus. They may also report, individuals with adult onset SMA may also report myalgia. One thing to note is that CK levels may be elevated and not helpful. EMG may show nonspecific neurogenic findings. Estimate genetic testing is the definitive test for someone who may present with these symptoms, that you're doing this, you have this diagnostic dilemma that you're trying to figure out, what does this adult have? Their weakness is mild, but it's life-limiting for them. So with these treatments, we're not done. We want to, Cure SMA is still focused on finding a cure. And in the meantime, we're going to keep supporting development of more treatments that improve quality of life, improve independence, improve this disease, which is devastating.
And I really want to thank you for updating us. Again, I've been speaking about the recently published article in Neurology Clinical Practice. It was in the August issue. The title is Spinal Muscular Atrophy Update and Best Practices, Recommendations for Diagnosis Considerations. We really just scratched the surface of some of the great material that's in that article. So please go look it up. And thank you for bringing us up to speed, Mary, and for the work you and the Cure SMA Foundation continue to do.
Thank you.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.